Daytime wetting is incontinence of urine or wee during the day in children over the age of 5. So we would expect children to be toilet trained by the age of 5, and daytime wetting before that age is of no concern. When children have accidents during the day, it's often accompanied by other symptoms, such as needing to go to the toilet very frequently, difficulty in holding their urine, urgency to go to the toilet, and sometimes voiding postponement. What this means is that children are not wanting to go to the toilet, either because they don't really want to use the dirty toilets in school or because they're too busy playing their video games. And this can sometimes result in daytime wetting. Nighttime wetting, on the other hand, is wetting that happens during the night, by definition. It sometimes has the same cause as daytime wetting, especially when children wet more than once a night. But more often, children wet in the very early hours of the morning, and therefore the reason is more related to the volume of their bladder and the fact that they're sleeping very deeply. And therefore the reasons for daytime and nighttime wetting can be different. The commonest cause of daytime wetting in children is actually not medical or psychological. The commonest causes are the fact that children are not drinking enough, and parents are often surprised by the amount of fluid children should be drinking. So for example, a 5 or 6-year-old should be drinking at least 750 ml of water in a day, and older children may need to drink 1.5 liters or sometimes even 2 liters a day for their bladder to develop normally. Some drinks are known as bladder stimulants, and they can cause the child to have daytime accidents. This includes blackcurrant, squash, and juices such as Ribena, fizzy drinks, caffeinated drinks, so teas, coffees, Lucozades, energy drinks. They can all worsen daytime wetting symptoms. Constipation is present in about 70% of patients who have accidents during the day, and it can be quite difficult to diagnose. So it's good to be aware of how often your child goes for a poo, whether it hurts to do a stool, whether it's taking long or it's painful, as this can also precipitate daytime wetting. The same goes for wetting at night. So being vigilant of how much your child is drinking and whether they're opening their bowels regularly is really important before considering further investigation. Sometimes wetting can be associated with medical conditions. These are actually quite rare, but there can be abnormalities of the spine, especially the lower end of the spine, the lumbosacral region, or abnormalities in the sacrum, which can cause wetting symptoms. It can also be associated with behavioral conditions such as ADHD and autism, and also it can be associated with hypermobility. It's sometimes compounded by psychological issues. So for example, children who come from separated parents or who may be bullied at school, that can compound the wetting because they're trying to hide the situation from their parents or their peers, and that can make the situation worse. But normally the baseline reasons are what I explained previously. The International Children's Continence Society, known as the ICCS for short, defines daytime and nighttime wetting as a problem only over the age of 5. So until the age of 5, daytime and nighttime wetting is quite common and does not need to be investigated further. However, it is always good for parents to be careful about how much their child is drinking, what their child is drinking, and to make sure they are not constipated when they appear to have accidents during the first 5 years of life. After 5 years of life, daytime and nighttime wetting can be prolonged. Once again, the commonest causes are not drinking enough, drinking the wrong thing, and constipation. Below the age of 5, the answer is no. Over the age of 5, we would first manage the baseline suggestions, which I've already described. We would normally perform some baseline investigations. The commonest would be a renal tract ultrasound scan with bladder volume and emptying. An ultrasound is completely harmless. It doesn't carry any radiation. We can make sure that the kidneys and urinary tract are normal, which they usually are. We can more or less assess bladder volume, and we can also see how the child is emptying their bladder. And this basically gives us some baseline information to reassure you that everything internally is fine. And it's usually something we can manage with behavioral modification and sometimes medicine, and that will usually fix it. In some cases, we would also advise an abdominal X-ray. An abdominal X-ray is very good at diagnosing constipation if we haven't been able to elicit this from the history. And it's also a baseline way of ensuring that the spine and sacrum of the child are normally developed. As I mentioned previously, very rarely there are abnormalities in the spine and sacrum which could result in a urinary and fecal incontinence. And those are just the baselines. Occasionally, when we find that our treatment isn't quite working, we may recommend further bladder studies. The baseline bladder studies are known as non-invasive urodynamics. And again, this involves ultrasound, and it's very minimally invasive. Extremely rarely, we would suggest a test called video urodynamics, which do involve catheters and radiation. So we only use this test in very selective cases where there is a medical cause for the wetting. The first step is always managing the baseline. Is the child drinking enough? Are they drinking bladder stimulants, drinks which we must stop? Do they have a healthy diet full of fiber? Have we managed the constipation? And just managing the baseline will treat and cure most daytime wetting in children. In some children, this alone is not effective. So we would start with medical therapy. The medical therapy for daytime and nighttime wetting is different. Daytime wetting often involves something called frequency, meaning the child is going to the toilet a lot, twice, 3 times an hour, needing to leave lessons in school. Urgency, so the sudden rush to go to the toilet, being unable to hold it. In girls, sometimes they would curtsy or sit on their heel to stop wetting. And this is sometimes quite difficult to manage just with conservative management. In that situation, we would start a child on a medication. There's various types, and your specialist will be able to advise on this, which will calm the bladder down. So calm this need to go to the toilet all the time. Calm the need to go to the toilet with urgency and not being able to hold it. And that really helps the child because it usually works. It solves the symptoms and it gives them more time to be able to drink, manage constipation and get on top of things, and then eventually would tail down the medication. There's various types of medication. Some are licensed in children, some aren't, but can still be used in children in lower doses. And again, your specialist will advise you on which medication is best for your child. When it comes to nighttime wetting, the situation is a little bit different. So as I mentioned, nighttime wetting is usually related to the bladder capacity, to the fact that the child sleeps really deeply and doesn't feel the sensation to need to go to the toilet. So again, we would start with the baseline management, stopping their fluid 1 to 2 hours before bedtime, make sure they go to the toilet before bedtime, but sometimes this alone doesn't work. In that situation, we would start the child on something called Desmopressin. My preference would be a tablet called Desmomelt, which just melts underneath the tongue before bed. And what this tablet does is it reduces the amount of urine or wee that the child produces at night. So until we're working on growing their bladder to last them the night, then they have a way of staying dry whilst we do that. Now, outcome studies have shown that the combination of Desmopressin with a bedwetting alarm is the most effective solution for nighttime wetting. So we would normally combine these treatments to expedite the resolution of nighttime wetting. Occasionally, children suffer from both daytime and nighttime wetting, and we may need to combine these medications. But once again, this should only be done under the specialist supervision of a pediatric urologist. If after the age of 5 you are concerned or your GP is concerned, then by all means, we would be very happy to advise. In particular, a pediatric urologist ought to see a wetting child if the wetting is associated with recurrent urine infections, especially if there are urine infections with fever, or if the wetting is associated with constipation or voiding postponement. And these situations really should be managed by an expert urologist. Other things to look out for are other neurological abnormality signs. So any signs that the child is having difficulty walking or running, or is feeling tingling in its legs, as that might require a neurological investigation, but that is very rare.